Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. And now we come to the last lecture of the respiratory system infection, and we're going to talk about Mycobacterium tuberculosis in this lecture. So pulmonary TB is caused mostly by Mycobacterium tuberculosis, and most of our talk for today's lecture is going to be about Mycobacterium tuberculosis. Though there are Mycobacterium tuberculosis complex, which contain 4 species such as Mycobacterium tuberculosis, bovis, africanum, and microti. And we have other species of Mycobacterium called Mycobacterium other than tuberculosis or non-tuberculous Mycobacterium, such as Avium intracellulare, Scrofolaceum, and these cause infection in the lung, similar to TB, or they might cause skin, soft tissue, and lymph node infections. Let's get back to Mycobacterium tuberculosis. Humans are easily infected with Mycobacterium tuberculosis but are resistant to the disease. And worldwide, we have almost or more than 2 billion individuals who are infected with Mycobacterium tuberculosis, and most of them, more than 95%, they are asymptomatic and they do not recognize or know that they have been infected with the bacterium. Only 5% of the infected people actually develop clinical case of TB. They infect healthy and immunocompromised individuals the same. So Mycobacterium tuberculosis is a non-motile, non-spore-forming aerobic bacilli, and it is characterized by having a cell wall which is rich in lipids. We call them mycolic acids. They are those ones in here. And so it is characterized by being hydrophobic and does not take the gram stain. It can resist many disinfectants and common antibiotic, and they can resist decolorization. So it needs a special staining, which we call acid-fast stain or Ziehl-Neelsen stain, in order to stain the mycobacterium. It has a generation time. It has a long generation time. So for the one colony to divide, it needs 12 to 24 hours. That's compared with 15 to 20 minutes for E. coli. And it is better grown in the presence of 10% CO2 and in pH of 6.5 to 6.8. There's a peptide in the cell wall which is biologically important, which is the tuberculin. And as a result of a growth of the Mycobacterium tuberculosis in the culture media, this antigen is going to be present within the culture media, and this is the antigen which is used for the skin test that we're going to talk about later. Mycobacterium tuberculosis replicate in non-activated macrophages. That's once it reaches the alveoli, it's going to be engulfed by the macrophages, but as we're going to talk in a moment, it's going to resist the phagosome, lysosome, and it's going to be able to multiply within the macrophage. Mycobacterium tuberculosis is not associated with production of any toxins or enzymes, and it does not really directly cause tissue damage or destruction within the lungs. Rather, the tissue damage occurs as a result of the immune system response to the presence of the Mycobacterium tuberculosis. So the first response is a delayed type hypersensitivity reaction to Mycobacterium proteins, resulting in destruction of non-activated macrophages. And the second is the T helper 1 activate macrophages, destroying Mycobacterium within their cytoplasm. And we're going to talk in a little bit of detail about how does it survive inside the macrophages and how the immune system plays a role in the coming. Mycobacterium tuberculosis is usually transmitted through inhalation of the droplets which contain the Mycobacterium tuberculosis. If these droplets get attached to the upper respiratory tract, then and does not reach to the lower respiratory tract or the lungs, then most probably the infection has not occurred. But if they get into the lungs, especially to the lower lobes of the lungs, then they are going to be faced by the alveolar macrophages. Alveolar macrophages are going to engulf the microorganism and is going to internalize it or take it up into the phagocytic vesicle. Usually once something is internalized into the macrophages within the phagocytic vesicle, what occurs is the lysosome attaches to the phagosome and release enzymes which can be able to kill any microorganism. But the Mycobacterium tuberculosis has a property to prevent the phagosome-lysosome attachment, and as a result it can survive inside the alveolar macrophage and also replicate and produce more Mycobacterium tuberculosis within the lungs. At this stage, we call it primary tuberculosis, and usually who are infected are the children, non-immune host. By this stage, most of them, they do not have symptoms at all, and they do not know that they're infected, or they might have flu-like symptoms. So after that, the immune system and the cell-mediated immunity specifically is going to kick in 1 week to 3 weeks after entry of the microorganism into the lung, especially the lower lobes of the lung, and it's going to form a granuloma in order to wall off the bacteria or to isolate the location of infection. And as a result, this is going to lead to necrosis in the center of the granuloma, and it's going to appear as a caseous necrosis because it resembles the cheese from the inside. Also, the microorganism might spread to nearby lymph nodes, and it might lead to also caseous necrosis there. The caseous necrosis at the site of infection is called gone focus, and the gone focus, in addition to the lymph node caseous necrosis, is called gone complex. Then this gone complex might undergo fibrosis and calcification and can be detected by chest X-ray. In certain patients, that is all it occurs, and the immune system is able to contain and kill the Mycobacterium tuberculosis, and this is going to lead to immunity and hypersensitivity against Mycobacterium tuberculosis, and those patients are going to be tuberculin positive, so they are going to be immune as a result of infection. And the story ends here, and it's a happy ending. Other patients who are immunocompromised or have AIDS, the microorganism might spread and become reactivated, leading to secondary tuberculosis, where it's going to go to the upper part of the lung. It prefers the upper part of the lung because Mycobacterium tuberculosis is an obligate arrow, and it prefers the upper part of the lung because of the abundance of oxygen there. So the cell-mediated immunity is going to kick in once again, but as a result of the cell-mediated immunity, cavities are going to form, and these cavitary lesions are going to spread the infection to the whole lung and lead to bronchopulmonary pneumonia, and that's what occurs in those patients who have HIV or immunosuppressive status, is progressive lung disease. And sometimes this might lead to these cavities might open into vessels, and as a result this would send the microorganism to the blood, leading to bacteremia, and as a result we call this miliary TB. Miliary TB is when the when the microorganism from the blood reaches other organs such as the central nervous system, the lymph nodes, the kidneys, the GI, the adrenals, and this is what's called miliary TB. Also, we have pre-allergic lymphatic or hematogenous dissemination, where the dormant tubercle bacilli lies in several organs, and it is going to be reactivated in adult life later on once there is a drop in the immunity. The coming slide would review the tuberculosis pathogenesis that we talked about in this slide. So first of all, the first step is droplet nuclei inhalation. So as we said, the droplet might contain a large number of microorganisms within, and a single cough or sneeze might generate more than 3,000 droplet nuclei, and they can spread up to 3 meters away. So the large droplets, they enter into the respiratory tract and become lodged in the upper respiratory tract, and in this case they are unlikely to develop an infection, but the smaller ones might reach into the alveoli and start infection, and at this stage this is primary infection, and most of those who are infected are asymptomatic or they have flu-like symptoms at this stage. Then it is engulfed by alveolar macrophages, and it has the ability to interfere with acidification of the phagosome by increasing the pH and then preventing phagosome-lysosome formation, and so it can survive and replicate within the macrophage. So 1 to 3 weeks later, the cell-mediated immunity is activated, and it's going to wall off or isolate the bacteria which replicate within the site of infection, and this is going to lead to the formation of a granuloma, and within this granuloma, this is going to lead to caseous necrosis within the granuloma. Then the T cells are going to recognize the Mycobacterium tuberculosis and release the cytokines, which are going to activate the macrophage and to destroy the Mycobacterium tuberculosis. The infected individual becomes tuberculin positive. This is due to cell-mediated immune response called delayed hypersensitivity. And the T helper 1 process is effective. The source of stimulation wanes and the disease resolves. So in the T helper 1 response, the activated macrophages are going to release interleukin-1 and tumor necrosis factor, and it's going to lead to the pathology or the tissue damage, and it's going to form the granuloma, which is has a caseous necrosis or has cheesy consistency, and they cannot multiply within the tubercle because of the low pH and the low oxygen content within the tubercle. The MTB can persist within these tubercles for extended periods of time. So for some of those who are infected, the immune system will going to be able to kill the microorganism, and that's it. For others, it's going to survive, and this is what we call latent TB. It's going to survive for longer periods of time, and this site of infection might become fibrosed or calcified, and we can see that on the chest X-ray. Stage 4, there is a tubercle, which is granulomatous lesion resulting from accumulation of macrophages, lymphocytes, fibroblasts, and multinucleated giant cells around the Mycobacterium tuberculosis. Although many activated macrophages surrounded the tubercle, many remain unactivated, and the Mycobacterium tuberculosis infect and replicate on those, and the tubercle is going to form and grow. Then if the tubercle may invade the bronchus or an artery or a vein, it is going to lead to the spread of the mycobacterium, and it's going to lead to what's called miliary tuberculosis. The caseous center of the tubercle liquefy. This liquid is very conductive to mycobacterium tuberculosis growth, and it begins to rapidly multiply extracellularly. And after a certain period of time, the walls of the nearby bronchi might become necrotic and rupture. This results in the cavity formation and the spread of the infection to other parts of the lung. Primary lesion heals by fibrosis and calcify. This is called Ghon complex. And some of the metastatic foci containing low number of mycobacterium tuberculosis may also calcify. Simon foci are visible by X-ray and are often sites of reactivation. Clinical manifestations, as we said, there is a primary TB. Most of the time they are asymptomatic or have mild flu-like symptoms. Chest X-ray infiltrate in the mid-zone of the lung and enlarged or calcified lymph nodes in the primary TB. And 5% of primary TB is not controlled and progress into active TB or disseminate to many organs. So 95% of those with primary TB is going to be controlled and healed, and the patient is going to have immunity against mycobacterium tuberculosis. Reactivation TB occurs after age 50, after 50 years of age, and it is seen in men more than women, and it's precipitated by immunosuppressive conditions such as malnutrition, alcoholism, diabetes, and AIDS. And the symptoms come up as dry cough, which then becomes productive with blood, fever, fatigue, night sweats, weight loss. And the reactivation of the extrapulmonary TB or the miliary TB might get into the meninges, causing meningitis. It might get into the kidneys, causing pyuria. It might get into the adrenals, causing Addison disease. Death might occur in 2 to 5 years of untreated in AIDS patients. So how to diagnose TB infection? First of all, a sputum sample needs to be collected in order for staining and culture to be done. And the gold standard for diagnosis of mycobacterium tuberculosis infection is the culture. So for acid-fast stain, we have 3 types of stain. The first is Zale-Nelson, Kinyon, and we have the fluorescent stain, which is called fluorochrome. And usually we visualize the acid-fast bacilli in the sputum, and this evidence should be an initial evidence of the infection with mycobacterium tuberculosis, but as we said, the gold standard is the culture. So this is an image of the acid-fast staining, and in contrast to the gram stain, we can see here that the acid-fast microorganism, the positive acid-fast microorganism, gives us a red or a pink color, while in the gram stain, the positive result is dark blue or violet color. So culture of mycobacterium tuberculosis, CDC has recommended that every effort should be made for labs to use the most rapid methods available for diagnosing mycobacterial testing, and these should include both a liquid and a solid medium for mycobacterial culture. And the gold standard is culture. We have the solid culture. As we can see here, the Lowenstein gentian media, and it has a green color because it has the malachite green within it, and growth on the Lowenstein gentian might take up to 8 weeks in order for colonies to grow. As we said, the generation time for Mycobacterium is long, 12 to 24 hours. So before 8 weeks has passed, we cannot label this as a negative culture, and the appearance of the Mycobacterium colony on the solid media resembles the bread crumbs. We have other culture media that we can use, liquid culture media such as the Middlebrook 7H9, and this might take 3 to 4 weeks for the growth of Mycobacteria on it. So it is a faster way or culture media to use when we're seeking quick results. Next, we're going to talk about the PPD or the Mantoux test, and the PPD or purified protein derivative test, and this is done to measure the delayed hypersensitivity to the tuberculous protein preparation, where we're testing if the patient has been previously exposed to the Mycobacterium tuberculosis or not. So in order to do that, we do take 5 units or 0.1 ml of the tuberculin protein, which is a product of the Mycobacterium tuberculosis, and we inject it intradermally, and then we ask the patient to come back after 2 to 3 days in order to see the result of the intradermal injection. If the patient has only returned 2 to 3 days later with only redness at the site of injection, then most probably this is a negative result. But if we have an induration and raised reaction on the forearm, then we need to look at the diameter of the induration in order to decide if this is positive or not. So if the diameter is 5 millimeter or more, we would consider that positive in certain patients who are severely immune compromised, such as the HIV patients, such as patients with who have recent contact with TB patients, patients with organ transplant. 10 millimeter or more is positive in those who are highly susceptible, such as injection drug users, residents in the nursing homes and hospitals, persons with clinical conditions such as those with diabetes, leukemia, end-stage renal disease, and children less than 4 years of age. 15 millimeter or more is positive in persons with no risk factor for TB. So for immunocompetent, healthy people, induration of 15 is considered positive. Less than 15 is negative. And those who had taken the vaccine, which is the PCG, Bacillus Calmette-Guerin, they would show induration of less than 10 millimeters. So this is the procedure: injection into the dermis of the PPD, and then reading it after 24 to 48 hours. So what's the treatment for Mycobacterium tuberculosis? We have a combination of a first and second line drugs. First line drug is a bactericidal, which kill the bacteria. Second line drugs are bacteriostatic, which inhibit the growth of the bacteria. And in case of Mycobacterium tuberculosis infection, drug combination should be used. So for the first 2 months, we should use isoniazid, rifampicin, pyrazinamide, and streptomycin or ethambutol, a combination of 4 drugs. And in the next 4 months, we should use isoniazid and rifampicin together. It's worth mentioning here that the least treatment protocol for patients with TB is 6 months. And the treatment protocol should be tailored according to the patient condition. So the least is 6 months. For patients, other patients might need to stick to the protocol for 1 year or 2 years, depending on their condition. And there is a chance of resistance. The patient might start on certain antibiotics, and during treatment he might have resistance against those antibiotics. If the patient had isoniazid resistance early on in the treatment, then we should use other alternative drugs such as ethambutol, streptomycin, pyrazinamide, or we can use also the second line drugs such as fluoroquinolones, but we need to extend the duration of the therapy. So the first line drugs are bactericidal drugs. They include isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. The second line drugs, we have the oral drugs such as fluoroquinolones. We have the intravenous drugs such as kanamycin and amikacin. And we have the less effective drugs such as cycloserine, ethionamide, and aminosalicylic acid, which are considered bacteriostatic. They hinder the bacterial growth. And as we said, if the resistance developed for the first line drugs, second line drugs should be used, but we need to extend the treatment period. What is considered inappropriate chemotherapy, or what is the inappropriate regimen for treatment? Monotherapy. Any case of infection with mycobacterium should not be given a single drug. And the treatment period should continue. If the patient, the therapy was tailored for 1 year, he should stick to 1 year and not take the medications for less than 1 year. And in certain cases where there is low absorption of the drug, then he should be evaluated and shifted to proper drugs. Also, there's a problem that has emerged on treatment of those who are infected with Mycobacterium tuberculosis, which is drug resistance. We have strains of Mycobacterium which were able to do to produce drug modifying enzymes and to produce drug efflux system, is that kicking the drug out, and also having hydrophobic cell wall. So mycobacteria undergo natural mutation which can lead to the development of drug resistance. TB is treated by administration of combination of chemotherapy, which decreases the probability of developing of the drug resistance. Development of increasingly resistant strain mainly due to patient non-compliance. And the number one cause of resistance development is non-compliance of patients to the drug regimen. Multi-drug resistant strains and is called MDR, and we have also the XDR, which is the extremely multi-drug resistant strains, has emerged as a result of non-compliance, as we said. In those patients with MDR and XDR, the mortality rate is increased 40 to 60%, and we have an estimated more than 50 million who are infected with MDR TB. MDR TB is approximately 125 times more expensive to treat than drug-susceptible tuberculosis. How to prevent TB infection? In case of close exposure to TB patient and or conversion of the PPD test from negative to positive, isoniazid should be taken prophylactically as an individual or a single drug for 6 to 9 months. Also, we have the BCG vaccine, which can be given. It's a live attenuated strain, which is given usually in the left shoulder within the first month of age, usually around 2 weeks after birth. It's part of the national vaccination program in Jordan, and it is contraindicated in immunocompromised patients such as the AIDS patient. As we said, any live attenuated vaccine should not be given for immunocompromised patients. Certain countries such as US, Australia, UK do not give PCG as part of the national vaccination program because the TB is not that spread there in their countries. They are TB free, and it interferes with the PPD results. So they do not give it as part of their national vaccination program. So this is it with for the Mycobacterium tuberculosis, and by that we have finished with all the respiratory tract infections in the respiratory module. Thank you and wish you best of luck.